My name is Paul Wischmeyer, and I am professor of anesthesiology and surgery at Duke University, where I also serve as the director of the nutrition team and the director of perioperative research for the Duke Clinical Research Institute. I'm spending a significant amount of time focused on increasing the role that nutrition plays in improving outcomes from surgery and perioperative care, and in particular, designing programs around the importance of nutrition screening and nutrition intervention in patients facing major surgery, with the real mission that no patient should ever have elective surgery in this country or any other without having nutrition screening performed and, when needed, nutrition therapy initiated. The specific clinical outcomes we can change with nutrition include infections, length of stay, readmission rates, and many other key things patients and doctors really care about. Malnutrition brings great risk to surgery. We know that 1 out of every 3 patients having elective surgery in the United States overall is malnourished, and 2 out of every 3 patients coming for GI surgery are malnourished before they have a surgical procedure done. And we know that the risks of complications are 3 times higher in malnourished patients who are having surgery, and the risk of death is 5 times greater. And we found in over 30 trials of over 3,000 patients, we could reduce infection 40% in these patients at the time of surgery, and actually reduce their length of stay by 2 days if we used immunonutrition just in the week before and or the week after surgery. The problem is we aren't diagnosing it, and thus we aren't treating it. In a survey we recently did of academic surgical programs in the US, less than 30% had any nutrition screening programs at all. And we found that only 1 in 5 malnourished patients were receiving any nutrition supplementation before their surgeries. So surgical site infection and surgical infections in general are a $10 billion a year problem in the US. Each infection costs thousands of dollars. And we believe these are preventable. So my question would be, how can we afford not to do this? How can we afford to allow the costly complications and infections our patients are suffering to continue to occur when, for a fraction of that cost, we could be screening for malnutrition and treating malnutrition, which is a very low cost intervention compared to the very high cost of complication, readmission, and infection we're facing because we don't screen for it.